We're going to get started just a minute. We're going to get started in just a minute. We're going to give a few more people a chance to get in. We have a lot of people trying to get in. So in the meantime, while we wait, if you wouldn't mind putting where you're calling from in the chat so I can see where you are in the world, that'd be great. Okay. Well, hello, everyone. Thank you for joining us today. My name is Catherine Blackwell, and I'm the Chief Health Equity Officer for the Allergy and Asthma Network. Welcome to this afternoon's webinar. We are in for a real treat today with Dr. Angela Hogan as today's presenter. Now, we have a few housekeeping items before we start today's program. First, all participants are going to be on mute for the webinar. We will record today's webinar and post it on our website within a few days. You can find all of our recorded webinars on our website at allergyasthmanetwork.org. All you have to do is scroll down to the bottom of the page to find our recorded and our upcoming webinars in case you'd like to tune into those. Now, this webinar is going to be about an hour long, and that includes time for questions. We will take those questions at the end of the webinar, but you can put your questions in the Q&A box at any time, and that's located right at the bottom of your screen there. We're going to have somebody monitoring the chat if you have questions or you need some help. We're going to get to as many questions as we can before we conclude today's webinar. This Advances webinar is in partnership with the American College of Allergy, Asthma, and Immunology. ACAAI offers CMEs for physicians and attendance credits for all others. You can create a free ACAAI account and obtain CME or attendance credits through the member portal for Advances webinar. All attendees are going to be offered a certificate of attendance, and no other continuing education will be provided. Now, a few days after the webinar, you're going to receive an email with additional information and a link to download the certificate of attendance. We're going to also try to add that link into the chat for you. So let's get started. Today's topic is SMART therapy and other patient-centered approaches towards asthma management. SMART therapy is for patients with moderate to severe asthma who need a combination treatment. Now, this combined treatment consists of an inhaled corticosteroid and an inhaled long-acting beta-2 agonist, also known as LABA. Under asthma guidelines, SMART therapy is recommended for people with moderate to severe asthma, including children ages 5 and older. It's considered an easier and patient-friendly treatment plan to follow. It is my esteemed pleasure to introduce our speaker, Dr. Angela Hogan. Dr. Hogan is a double board certified in allergy and immunology and pediatrics. She practices at the Children's Hospital of the King's Daughter in Virginia. Dr. Hogan is passionate about community education in asthma and food allergies. She feels it's very important to not only get the correct diagnosis for food allergies, but also important to understand the impact such as a diagnosis has on a child and the family. She formed a regional food allergy support group called FASGOT.com, that's FASGOT.com, which helps healthcare providers, schools, and families deal with food allergies. She is extensively involved in the education of, of the school nurses in the 7 districts in her area, and has organized outreach programs for community physicians. For Dr. Hogan, CHKD really is more than just a hospital. It allows her to teach not only families, but also future doctors in pediatrics and allergy. It supports her as she tries to work in the community, and it allows her to do clinical research. Dr. Hogan chairs the Asthma Committee of the American College of Allergy, Asthma, and Immunology. Dr. Hogan, thank you so much for being here. I'm going to turn it over to you now.
Okay, well, thank you. Thank you all for joining us this afternoon. These are my disclosures, and they're not relevant for today. So our learning objectives, we are going to talk mostly about SMART, but I do want to mention a little bit about what you would do with patients who have asthma that might be at step 1 or step 2. We're going to discuss also how to practically implement these into your practice and why that's important. And then we're going to talk a little bit about focusing on patient-centered treatment and how that can improve the quality of care that we deliver to our families. So let's just review first again, what is asthma? It's a chronic disorder. It has a couple of main components, the most important of which is airway inflammation. And then the second one is bronchial hyperresponsiveness. And in order to be asthma, we know that the airway obstruction needs to be reversible. We know that asthma is not just one disease. We talk about asthma as if it is, but there are multiple different risk factors for the development of asthma. There are differences in triggers, there are differences in symptoms, severity, and even responses to therapy. One therapy doesn't necessarily fit all asthmatics. And then we know what other comorbid conditions patients may have may also impact their response to therapy and also the severity of their asthma. We know that asthma is a really big deal financially in this country. It is the most common chronic disease of childhood. The overall pediatric prevalence is about 6 to 9%. In adults, it can be as high as 10 to 12%. In children, we know that about 50% of them have uncontrolled asthma. And if they have uncontrolled asthma, it costs a lot more healthcare dollars. They overutilize the healthcare system when they're poorly controlled. And actual severe asthma in children only makes up about 5% of pediatric asthmatics, but that accounts for about 50% of healthcare dollars that are spent. Economically in this country, asthma costs about $56 billion, which obviously has a big impact on our healthcare system. In terms of thinking briefly about asthma epidemiology, we know that there are different prevalences across different populations. It does vary by race and ethnicity. And we know that asthma disproportionately affects the Black population. As you can see here from this graph from the CDC, looking at age and sex and ethnicity, there are some disparities noted here. We also know that asthma mortality has overall been pretty stable. We know that about 11 people in the US die each day from asthma. We did see when we looked at asthma mortality trends that we were on the downward slope, but in 2020 we saw the first rise in asthma deaths, and the most recent statistics say that this trend may be ongoing. We also know that adults are 6 times more likely than a child to die from their asthma, and that again there's a disproportionate effect. Black individuals are 3 times more likely to die from their asthma than white people. And we know that the death rate is the highest among individuals who are 65 years old or older compared to the other age groups. So we know that asthma really impacts utilization. There are 750,000 ED visits per year for asthma. There are 200,000 hospitalizations annually. And we know currently the mainstay for an ER visit or hospitalization is still inhaled bronchodilators and systemic corticosteroids. So the biggest place to make an impact on asthma improvement in healthcare is, can we do that as an outpatient and try and keep them from needing to go to the emergency room and being hospitalized? So what we have found most recently in that our thinking about asthma is probably all wrong. We have been thinking about asthma as a disease that involves predominantly bronchodilation. and that the airways are constricted. And we really understand the problem that airway inflammation plays a huge role in this, and that asthma morbidity and mortality are actually very preventable when we understand the importance of addressing airway inflammation. When we think about what resources you could go to understand asthma a little bit better, there are two main resources that are available for most people. There are the national asthma guidelines that are put out from the NHLBI. The most recent update was published in 2020. And then there is the international guidelines or initiative that people use as a resource called the Global Initiative for Asthma, which most of us call GINA. And they update yearly, and the most recent publication for 2024 is already published now. The Global Initiative for Asthma, as I said, do not necessarily consider themselves a guideline, but more a global strategy. And those are geared towards PCPs and also focus very much on the newest evidence-based medicine. And the NHLBI guidelines were first published way back in like 1997. One of the biggest asthma updates was in 2007, where we use a lot of our resources. But in 2020, they did put out a new updated focused on 5 or 6 different areas of asthma that we currently are following also. So how do these two guidelines differ from each other? They're very minor things overall. Where they split the age of asthma is off by about 1 year between the two. The number of steps that each of one of them considers steps in asthma care. And then also when they assess asthma severity is different. In our national guidelines, severity is determined at the initial visit. In GINA, they assess severity after they've been on therapy for 2 to 3 months. And so what are the goals, according to GINA, of our asthma management? It all depends on a lot of things. It depends on what the patients are able to understand, and also what are their preferences in terms of how they want to manage their asthma. But GINA feels like all patients should have few to no asthma symptoms. They should be able to sleep and run and play and work without any impairment. It would be nice if they can maintain normal lung function. We'd like for them to have no asthma flares at all. And we'd like for whatever medications we pick for them to have minimal side effects. And overall, whenever possible, we'd like to avoid oral corticosteroids because they have such long-lasting impact and can be very helpful, but in the long run, lead to a lot of morbidity. When we are thinking about our asthma management, we need to again think about what's the asthma phenotype that we're treating. How well can the patient adhere to what we're asking them to do? Are they concurrent smokers? We also want to make sure that what we pick is cost effective for that family and that it's available. And again, we want to constantly review what we put them on, reassess how they're doing on it, and adjust those therapies. The little circle there on the bottom is taken from GINA, and GINA says that every visit that we see asthmatic patients, we should be reviewing and assessing and adjusting their asthma care. So first, let's talk a little bit about albuterol. We are really looking at albuterol or short-acting beta agonists kind of in a very new light. What we know essentially is that unopposed albuterol, meaning albuterol used only by itself, can actually be dangerous. If we use a regular short-acting beta agonist for only 1 to 2 weeks, a couple of times a day, then we actually lead to tolerance in the airways to responding to that short-acting beta agonist, and we see reduced effectiveness and increased airway hyperresponsiveness. So we need to quit thinking that all we need to prescribe for a patient is albuterol, because actually short-acting beta agonists have been shown to have a lot of risks, even associated with exacerbations and fatal events. And we sort of propagate this response for patients because albuterol is inexpensive and it does provide rapid relief. And so it's sort of the family focuses back on the fact of, oh, let me grab that rescue inhaler. And we always ask those questions. Where is your rescue inhaler? How much are you using your rescue inhaler? And we really don't talk about the other part of asthma treatment, which is addressing the airway inflammation. So what we know is that actually we should be thinking and talking a lot more about inhaled corticosteroids. We know that inhaled corticosteroids actually decrease that airway hyperresponsiveness. They decrease the risk for an asthma flare. They decrease mortality. They actually decrease the eosinophils in the airway also, which we know is very important to address when we are thinking about the best management of asthma inflammation. And they also keep us from remodeling our airways. So inhaled corticosteroids are playing a very important role when we think about asthma. And what we know that even mild asthma doesn't necessarily mean that you're safe. We know that individuals who do have mild asthma can have a very severe asthma attack and possibly even a fatal exacerbation. And part of the problem when the asthma is really mild is that everybody thinks it's mild asthma, so they don't always take their medicines the way they're prescribed. And that, again, when they start having symptoms, the inhaler they reach for is that short-acting beta agonist. And so they may be at risk for developing a tolerance to their response to that. And even when we do prescribe an inhaled corticosteroid for patients, oftentimes that maintenance medication is only consistently taken about 30 to 40% of the time. And in a recent systematic review, it found that 24% of 24% of exacerbations were related to poor adherence to their controller therapy, and 60% of hospitalizations were because patients weren't taking their inhaled corticosteroid. So there's a strong evidence to suggest we need a safer way of teaching patients to manage their asthma than just short-acting beta agonists. So that's where we are going to come in with SMART or MART therapy. So what is SMART, MART? They're actually interchangeable terms, and we'll come to that in just one second. And most people will say SMART because it's a cute little acronym, but they're interchangeable. MART is actually using a particular type of medication that's 2-in-1 inhalers, and it uses an ICS, and it uses formoterol. And formoterol, as you know, is a long-acting beta agonist that actually has the ability to act a lot like a short-acting beta agonist also, because it has very rapid onset. And so what MART actually is it's using both of these medications today in one inhaler. And so we're going to spend a fair amount of time kind of reviewing that and then talking about how Gina recommends we should apply those. So for MART or SMART therapy, basically, again, you have one inhaler and it's used as a maintenance and a reliever. And then you increase the use of it when you're sick. And then when you're well, then we dial it back down. And so in this particular country, there are two preparations that are available that have formoterol. There is a budesonide formoterol inhaler, and there is also a memetazone formoterol inhaler. And again, it has to be formoterol, or it does not count for all the studies and the things we're going to talk about that make SMART helpful. And there is another product that we're going to talk about that's on the market that is an ICS SABA, but it cannot be used as a maintenance medication. So it's important that we know the difference between the two of those. And in 2023, in the GINA guidelines, they sort of rechanged our terminology, and that's where the word MART came from. And prior to that, it had been SMART. So the terms that I want you to know and understand today are, first, we talk a little bit about AIR. And what AIR is just using anti-inflammatory as a reliever. So you're going to have this combination products that are ICS formoterol or ICS SABA, and they're used only when you need them. So they're just rapid relief medication. But the thinking is that if you're using a short-acting beta agonist by itself for symptom relief, something made you need to use that for symptom relief. And so when we put the two medicines together, an inhaled steroid will help chase away whatever it was that made you need to use that inhaler. So it's better to have both the cause and the symptoms addressed together in one inhaler. And that's what we're moving towards with our asthma therapies. And this particular combinations of medicines, the ICS formoterol and the ICS SABA, they can be used before exercise also. Sorry, I got tongue-tied. And when we talk about asthma therapies, we use them in steps 1 and 2. And then MART or SMART is using it for both maintenance and reliever therapy. So that's what SMART stands for, single maintenance and reliever therapy, or MART, maintenance and reliever therapy. And again, the only medicines that can be used for this are ICS formoterol. And a couple other terms that they also redefined in 2023 is they like the word maintenance to replace the word controller, and they also like the word reliever to reflect what your as-needed medication is for quick relief. So now that you know all the terms, how do they work? So let's first attack asthma in adolescents and in adults who are 12 years of age and older. So one of the huge points from Gina is that they feel like no patient should ever be prescribed a short-acting beta agonist alone ever. Again, because the short-acting beta agonist gives you relief of the symptoms, but it doesn't address whatever the cause was. And so the feeling is that there should always be 2 medications together, according to Gina. And so what we know is that this particular combination can be used a couple of different ways. And in Gina, they've proposed certain asthma tracks on how we look at treating asthma. And so this is what the Gina 2024 guidelines look at. And I want to just spend a minute and go over these so you can understand them if this is new to you. So there are basically 2 tracks. There's the top track, which is track 1, and there is the bottom track, which is track 2. Track 1 is the preferred track. And what we see there is that there are basically 5 different steps for asthma, and each step is a little more significant asthma. And in patients who have very mild or mild intermittent asthma, the current guidelines recommend that we just use an as-needed low-dose ICS formoterol whenever it's necessary. And then as asthma gets a little worse, then we step up and start both a maintenance and a rescue with an ICS formoterol, and then a little bit higher dose at step 4. And then at step 5, it becomes more difficult to manage asthma, and we start looking as additional add-on medicines, and also start considering asthma phenotypes that we might consider for biologics, which is beyond the scope of the lecture that we want to talk about today. So again, I want to just point out track 1 here, which is again using ICS formoterol as both the primary reliever medication and also as the controller. And what we know is that this particular way is a very good way of managing asthma, because what we know is that this particular way allows you to step up and step down without having any particular issues. You dial up for increased symptoms. It avoids confusion about different inhaler techniques with different devices, and that a single medication can be used for both symptom relief and maintenance. So patients are not trying to jumble or figure out which inhaler they should be using when. They just have one single inhaler. Sometimes the insurance companies, as you know, 1 month they like this particular inhaler, and the next month they like a different device. And sometimes I have patients who will bring in their bag of medicine, and they'll have 3 or 4 different things, and each one of them may have a different technique on how they're supposed to use those medicines, and it can become very confusing, and patients can do them improperly, and then obviously they're not going to get optimal asthma control either. So with this particular method, it allows them to dial up and dial down. We also know that there's a great amount of science that shows that Gina does really have good evidence-based medicine to support that this works. We know that in steps 1 and 2, when ICS formoterol is used alone as rescue, that there are more than 10,000 patients in long-term 12-month studies that show that this is superior than just using albuterol alone, or even using an ICS plus albuterol if the ICS is used every day as a separate inhaler. We also know that for MART in steps 3 to 5, that there are more than 30,000 patients in studies that demonstrate that not only is this superior in terms of effectiveness, but it's also very safe. And so we have many studies that demonstrate that this is the preferred method for asthma treatment. And so when we look at our national guidelines from 2020, they actually adhere to what Gina recommends at step 3 and step 4. Our guidelines from 2020 are based on some outdated information, and they still prefer as needed albuterol for intermittent asthma. And then every time you get an inhaled steroid, or every time you get a SABA, they want you to match it with an inhaled steroid at step 2. But you can see here at step 3 and step 4 that they actually parallel Gina exactly. So you want to have a little science behind this to say, why is this the preferred way? And I have that in the next slide for you. What I want to show you is a Cochrane database systematic review from 2021 that look at step 1 and step 2. And in this particular slide, what I'm demonstrating for you is that ICS formoterol, when compared to albuterol alone, is able to demonstrate a 52% reduction in the use of oral steroids in patients with mild asthma. And ICS formoterol, when compared to albuterol alone, has a 65% reduction in usage of the emergency department or hospitalizations. And most people think that Cochrane analysis are a very good way to demonstrate evidence-based medicine. And if we also look at the Cochrane review for how does ICS formoterol compare to people that are on daily ICS and as needed SABA, what we find is that there's a 20% reduction in the need for oral steroids when you use the combination medicine compared to 2 separate inhalers. And there's a 37% reduction in emergency room visits and hospitalizations when the 1 inhaler is used instead of 2 separate inhalers. And in addition to that, we know that Gina does say sometimes insurance doesn't allow you to use the ICS formoterol product. And what they are recommending is that in step 2, perhaps we consider using an ICS SABA so that we don't have abuse or overuse of albuterol alone. But it does recognize that there will still be some insurance plans and individuals who will still be using other ICS LABAs and SABAs. We don't ever mix ICS LABA with an ICS formoterol as rescue. That really doesn't gain you anything, and there's no evidence to say that using 2 different kinds of LABA together is safe. So we usually don't recommend doing that at all. But that ICS SABA that I mentioned, for those of you that may not be aware of it, in January of 2023, we had arrive in the US market our first product that actually links an inhaled corticosteroid to albuterol. And this product is available on the market now, and it's available for 18 and up. So if you had someone that you traditionally might have just prescribed albuterol alone for, Gina would say, don't do that. What you should do is actually make it albuterol and the budesonide together in 1 inhaler, because that's going to be much safer for those individuals. So this is what it looks like together when both tracks again are there. And as you can see again, step 3 and step 4 talk about MART, and that's what we're going to focus on for just a minute. And again, MART is the same as SMART, and it means maintenance and reliever therapy. The previous slides there I was showing you again were for steps 1 and 2, and now we're going to move on to steps 3 and 4. So for steps 3 and 4, let's talk just a minute again why we think MART is better. Again, not only because it's simpler, but because we have 1 inhaler that the patient needs to deal with. And we know that there is good evidence to show putting it all together in one appropriate inhaler also reduces the risk for them to use oral corticosteroids, and also reduces exacerbations. And so there's even some data that shows using ICS formoterol products actually improves the blood eosinophil levels. In this particular slide, it shows you that in this particular one, beclomethasone was the ICS that was used with formoterol in this study, and it showed that MART was more effective than ICS LABA plus a short-acting beta agonist in reducing eosinophilic asthma and reducing the number of eosinophils in the blood in both people that had eosinophilic and non-eosinophilic. And it seemed to have even a bigger impact on those patients that had more eosinophils. So it's important to know that not only is it helping symptoms, but even at a cellular level, it is decreasing inflammation. So when we look at our national guidelines, again, by step 3 and step 4 in this particular age group, it looks very much like GINA. You can see that, again, they talk about using the combination of an ICS formoterol, both as a maintenance medicine and also as a rescue medicine. We use a lower dose at step 3, and then at step 4, we increase to a higher dose of that medicine, meaning more puffs, so that we can control their asthma better. So what do you need to tell patients? Well, one of the things you need to tell patients is that this combination product will work just as well as albuterol. I occasionally have patients that are so dependent on albuterol, they're very anxious to give it up, and they're afraid, what if it doesn't in fact help me as quickly? But you can reassure patients that it has both the ability to have a rapid onset, and then also, like long-acting beta agonists, it has the ability to have a long-acting effect also for bronchodilator and decrease inflammation. And then the question comes up, okay, what are we going to do for school? Are we going to send an albuterol inhaler to school and then have them have their controller medication at home? That's a combination therapy. And the current recommendations are actually we should be giving them multiple combination ICS formoterol products all in the same month so that they can actually have one to leave at school. In our state of Virginia, we've been able to get the state Medicaid to approve 3 inhalers for our patients per month so that they can have one to send to school, they can have one for the soccer bag, and they can also have one for home because that's what we're going to need to do. And oftentimes we'll even have patients who go to the emergency room, they're treated there, and then the ER physician or ER provider will want to immediately prescribe them albuterol as they leave. And we need to quit confusing the picture and continue to focus on the fact that they need to have combination therapy available at multiple places and that they just need the one medication. And then the question always comes up with previous inhalers. We have always said, you know, brush your teeth right after you take it, and that you need to rinse and spit and drink something. What we're really finding is that with most of these medications, specifically budesonide and formoterol product, we're really seeing very little thrush. And so the current recommendations are from GINA that maybe if you're doing 2 puffs and it's your maintenance medication for the day, you may want to go ahead and rinse and spit. But if you are doing pre-treatment with exercise or doing an as-needed dose, you probably don't need to rinse and spit. And again, the risk of thrush is very, very low. We know that it really is important for patients to have an asthma action plan. That's not anything new. It's been in our guidelines for lots of years. But as we start to explain to them AIR and MART, it can be a little bit confusing. So we want to make sure that we spell it out for them very clearly what kind of action plan would entail if they are deteriorating and going into their yellow or red zone. So first, let's talk just a minute about, well, how many puffs do we use for each part of it? And then we'll look a little bit about action plans. So when we look at GINA, GINA says if we are using the combination product in kids and adults over 12 at step 1 and 2, that they probably only need to have probably just one inhaler and one puff should be fine. When they move to step 3, then again, it's the same inhaler, and they can take one puff as their maintenance medicine once or twice daily, and then as a rescue, they would take an additional one puff. And then as they move to step 4, as they may be having more significant asthma, again, the same inhaler, but they would take 2 puffs twice a day, and then one additional puff as a rescue inhaler. And it sort of is a little bit tricky, because the way that we've looked at asthma inhalers in the US and what is currently FDA approved for these inhalers is not the same way that Gina says we should be using it. So Puff the Magic Dragon in our particular slide here basically says that a rescue puff is all that would be needed, but most of our MDIs in this country, when you look at their what it says in their drug wording, it actually says that it's not approved for rescue, and it also says that most of those inhalers should be given with 2 puffs. That's kind of based on old information. Some of our early MDIs, we felt like the medicine may not get completely through the inhaler, so oftentimes we would do 2 puffs to try and push the extra medicine through. What we know now with most of the MDIs that we currently have on the market, that 1 puff can effectively get all the way through the device and can be delivered effectively. So as stated, Gina says that we really only need 1 inhalation for symptom relief. And then if we're not seeing significant improvement after a few minutes, then we could do a second puff. The other thing, again, that Gina says is that other ICS formoterol products that are available haven't really been studied as well internationally and in most of the trials. So when we talk about in this country, the only combination therapy that has been studied well and that's available on the market is the budesonide formoterol product. There is also the mometasone that is available, mometasone formoterol product that's available in this country, but it really has not been well studied, and those studies are pending. So Gina does not necessarily say that that is the product that we have a lot of data for. In Europe, there is a beclomethasone formoterol product, but that's not available in the United States. So this is the nuts and bolts of it all. So what strength ICS budesonide formoterol are you going to prescribe for a patient, and how many puffs are you going to give them, both as their maintenance and for their rescue? And so let's walk through this table for just a moment. So if you have a patient that's over 12, then the current recommendations from Gina are that you should prescribe the 160 per 4.5 budesonide formoterol medication. If they are getting air only, which means just as needed, they would just take 1 puff as needed for exercise or for reliever. If they're going to be on SMART or MART, depending upon what their severity is, then they would start out with 1 puff once a day or twice a day in step 3, with 1 puff as a reliever. And if they had more significant disease, then they would get 2 inhalations twice a day with 1 puff as rescue. I want to note for you that the maximum daily number of puffs that someone over 12 should be getting is 12. That's how I always remember 12 for 12. And beyond that, it's not recommended to go beyond that. If you have an asthmatic who's younger than that, we know that in the 6 to 11-year-old groups, if we were using this particular therapy, we would want to write the 80 per 4.5 of the budesonide formoterol. In step 1, currently there is no evidence, although there are ongoing studies, there's not enough evidence for Gina to recommend air therapy in patients 6 to 11. But they do endorse MART therapy at step 3 and step 4. And the appropriate way is, again, At step 3, 1 inhalation once daily with 1 rescue puff. And at step 4, 1 inhalation twice daily with 1 inhalation as rescue. And you can see the number of total puffs in this particular age group is 8. I've gone ahead and put on this table for you if you are going to use mometasone for Motorol, which is a product that's available in this country, and what your standard dosing would be for SMART or MART if that is the inhaler that the insurance company wants to pay for. So let's just talk briefly about asthma in the 6 to 11-year-olds. There are some things that, again, are just a little bit different. In the 6 to 11-year-olds, they say, as I mentioned, we do not have air therapy approved, but if they had to use a SABA, you would want to match that with an inhaled corticosteroid. And then you can see at step 3 and 4, we actually can then begin using MART, as we mentioned in the previous table. And you can see here, when it's all put together in the GINA 2024 schematic here for 6 to 11-year-olds. Again, prior to that, SABA would be used for step 1 and 2, and then in step 3 and 4, we would move to the combination product. So, and the dosing, as I mentioned, is very simple. And again, I do want to mention that we don't want to use ICS for Motorol as a reliever with other ICS LABAs. That's just not really been demonstrated to be the appropriate way to dose them. So, and this is what it looks like in our NHLBI guidelines, which is very matched, at least in terms of matching GINA at both steps 3 and step 4. They again endorse MART in this particular case. And so they also talk about matching, at least in step 2, an ICS with a SABA in patients that are using one, so that we don't have unopposed albuterol, at least at step 2 level. All right. And then again, bringing into you that I just mentioned about the mometasone. So let's spend just a few minutes talking about what can we do to have patient centered asthma care. I think one of the most important things that we need to do is have shared decision making. So when I am meeting with my families, I talk about for them what they've used in the past and how it's working. I spend a lot of time talking about our new understanding that if we use albuterol excessively, that can be dangerous. And I try to fit how we dose their ICS formoterol combination at once a day. Would that be easier in the morning or easier at night? I make sure that we have the appropriate inhalers available at school. So we discuss the pros and cons of different treatment options. And I think it's always important that we give them a say in what they're looking for. I think it's very important to have personalized asthma action plans. This is reiterated both in GINA and in the NHLBI guidelines, that it's very important that patients know what to do on an everyday basis and also what to do if things are not going well. So here's an example of an asthma action plan that's available on the Allergy and Asthma Network. And you can see here, SMART is incorporated in that. And what we would note here is that you would tell patients how many puffs to take when, how many puffs would be their rescue. Remembering again, it's 12 above 12, and under 12, it would be 8. And then there's also a certain number of puffs you can take when they are in the red zone. In this particular example, if they're in the red zone, then they would take 1 puff of the budesonide formoterol product, wait 1 to 3 minutes. If they're no better, then they would take additional puffs, and they could repeat that in the red zone up to a max of 6 puffs as they are accessing additional healthcare facilities or resources. This is what our action plan looks like in the state of Virginia. Just as an example, it again incorporates both the ability to do SMART and also more traditional asthma combination medications. And this is also the asthma action plan from the NHLBI. And so I'd recommend that you get an action plan that fits your community that can be easily utilized. And I think it's very important. In our particular Virginia Pediatric Asthma Action Plan, we wanted one that we could populate in our EMR so that it could stay there, and then the parents could go on the portal and be able to pull off their action plan anytime they needed it for the YMCA or somewhere else. So I think having access in the EMR may be very helpful for patients to be able to have their asthma plans. I think it's also that important, as we mentioned, from the little circular things that the top of the screen there, review, assess, and adjust. I think each time we see an asthma patient in follow-up, we need to see what's working and what's not working. We need to try and teach them again the importance of their inhalers and encourage, I think, self-monitoring of symptoms. And if they're an adult, peak flows can also be helpful. There are lots of apps that are available that in very motivated patients, they can go in and sort of rate their asthma for the day. They have like ACT scores that are built into apps. And some practices that are very savvy with electronics can even have those communicate back with their provider. I think it's important that we utilize all the people in our facilities to help provide patient care. It may be that we need to have a we need a team approach. And I think it's important that specialists are talking to primary care so that everybody's on the same page. And then as we involve the emergency room, people also, they need to understand what SMART is and how that works also. And I think things like clinically integrated networks can be very helpful also. So across states and populations, everybody is helping to provide a uniformed vision and understanding of asthma management. In addition to that, I think it's really important to have regular follow-ups. Some individuals who have difficult to manage asthma should probably be seen at least every 3 months, and it's good to see them when they're well, just as it is to see them when they are not well or having an asthma exacerbation. And again, I'm amazed every time I try to review asthma technique, how quickly they can forget how to use their spacer, and we have to review that over and over again. And also telemedicine, for those of you that have the ability to use that, can be very helpful in establishing routine care and follow-up. And we're just checking in and seeing how you're doing with your asthma. I also find on the EMR, being able to track how often they refill their medications is very helpful, and also lets me tell them I know how often they're refilling their medicines. It's an opportunity for me to stress to them the importance of good adherence to refills on their medications. I think that it's important when we see patients that we also address healthcare disparities. It's very difficult to want to manage asthma from my seat if when they go home, they are having difficulties maybe getting transportation, or even they don't feel safe, or potentially they don't feel supported by their family. In terms of the adjustments that need to be made for families with chronic illness. We want to provide things that build independence and self-efficiency, and we want to address asthma disparities as they occur across the healthcare system. And I think it's really important that we think about medication costs. It's very difficult to say, go and get this wonderful new asthma medication, and I want you to have 3 of these inhalers, 1 for everywhere you go, but then the cost of those inhalers is prohibitive. We also need to make sure that the action plans that we use and the information that we communicate to the families is understandable to everyone, including the kids need to understand a little bit about the importance of their asthma medications if they are old enough to understand that. And so I think having resources at each point of care that can help address some of these barriers is very important. There was some good news that came out on June 1st. There were at least 3 different pharmaceutical companies that placed a price cap on several of their brand asthma inhalers, and they are to be no more than $35. And so what I found in my particular area is that I've been able to print a coupon for certain brands to hand to the families, to give to the pharmacies, or in the state of Virginia, as I mentioned, we've been very fortunate, and Medicaid has embraced that these inhalers are important and they're covering them. Additionally, sometimes I will tell them that they should, if the insurance says, oh, it's going to be $60 or $160, I tell them to have the the pharmacy just take the insurance out and run their prescription through as if they had no insurance. And what I am finding, then it is popping up at $35. So I think this price cap from these pharmaceutical companies are going to have very good impact on patients' accessibility to being able to get these inhalers. So I think that there are many, many hurdles that we still have to overcome. There are still a lot of people that are really hung up by the fact that here we are advocating this is the way to treat asthma, and the FDA has not approved that these inhalers can be used as a rescue inhaler. But I think that if it comes, it will come in due time, and that really we need to follow where the evidence for science is. We have, you know, 2 great asthma documents that say this is how we should be managing asthma. This is how we provide safe asthma care for patients. And we need to throw out our old-fashioned view that asthma is just a disease of bronchoconstriction. And then we need to make these medications available, and we need to focus on healthcare system integration, and we need everyone to understand. And I think that somewhere I read recently that anytime new guidelines are written, that it can take up to 12 years before new guidelines in any chronic disease can actually take hold, and that everyone learns about it and is able to implement those for patient care. What I'm really hoping is that we don't take 12 years to be able to implement our new understanding of asthma, that it's really important that we prevent disease, prevent exacerbations, and make one inhaler available for most patients that are at step 3 and step 4, that makes it much easier for them to manage their asthma. So I think that's all I want to say, other than here are some additional resources from the Academy of Allergy, the College of Allergy, the Allergy and Asthma Network, and also the Asthma and Allergy Foundation of America. They all have great websites with lots of information about SMART and also how to address healthcare disparities.
Okay, Dr. Hogan, thank you so much. Wow, that was a lot of great information. We need more time. I wish you could see all the questions. We have a lot of questions in the Q&A, but we also have a lot in the chat, and I'm going to do my best to summarize everything so that we can answer everybody's questions. So there were a lot of questions that you can probably imagine about the insurance issue, about insurance companies not being familiar with GINA. And because of that, they're not able to process the prescription. And, you know, someone was saying that they're really having a difficult time with insurance coverage for ICS or for formoterol inhalers, and that insurance companies often won't cover these inhalers and will only cover ICS or salmeterol as preferred treatment. So a lot of the patients are unable to afford the out-of-pocket cost of Symbicort and Dulera. And, you know, just basically, you know, this is what I've been hearing throughout the webinar here with all of the questions. Do you have any suggestions on how to educate insurance companies regarding guidelines, SMART, MART, and changing the coverage?
Yes, I do. So first of all, if you are a member of the college or have access to the ACAAI website, there is a letter there that was recently written that helps you get prior authorization. It's a multifaceted level with good evidence-based medicine, and you could adapt that to your individual patient and argue why this particular medication could be or should be covered. I think that there are many, many people that are working across the country to try and overcome obstacles. I know in our particular area, you know, I've recently written a 5-page letter to some of our insurance providers discussing why this is the superior way. I think things are going to get better, but on a practical note, I so far, will knock on wood, have been able to tell my families, again, because of this recent price cap, to tell the pharmacist to take their insurance completely out and run it through as if they had no insurance. And so far from what I've heard, and hopefully I'm still right, then it is $35 because of the price cap. And so that may enable them to at least get one inhaler for $35.
Okay. It was another comment and a question. At a recent conference, we were informed that the shelf life of an inhaler decreased drastically once an inhaler is open, that the expiration date on the box is the date of expiration if the inhaler has not been used. So how do we assist families if they need inhalers for school and home every 30 to 90 days due to the shelf life? You want to any comment on that or?
So I'm not sure that the shelf life is the same for all of those inhalers. And I think it depends on what the preparation is. Certainly for dry powdered inhalers, we know that the moisture can get into those and they may have a shorter half-life. When the inhaler is an MDI, they have longer shelf lives, as clearly evidenced on the box. So I'm not sure that that applies universally across all inhalers.
Okay. There's a question about ICS and perioral dermatitis for patients with asthma 5 to 6 years old. Have you successfully managed someone's asthma when their face is constantly battling this rash on their face?
So we do see a perioral dermatitis. We do in fact see that less. Some again with the budesonide formoterol, also because we see less thrush with that, or at least that's what my clinical experience has been. Usually what I do with those individuals is I make sure their spacer is clean, because it's usually the patients that have a mask spacer. If they are someone that I can switch to a mouthpiece spacer and I feel like that they can do that appropriately, that sometimes will overcome it. We know that actually topical steroid creams don't make that any better, so don't apply topical steroid creams. Sometimes you can use Elidel can sometimes be helpful. Sometimes we will use Metrogel or metronidazole. That can also help with the perioral dermatitis.
Okay. And then there was a question, are you currently writing your SMART prescriptions as 2 puffs twice a day and then just telling your patient to use it based on the SMART guidelines?
Yes. So actually, I am writing it as if, especially if they're an air patient, I am writing it as if I were prescribing it as 2 puffs twice a day, because that's what the package insert says. And then I am telling them to follow the asthma action plan. And I'm spending a lot of time making sure that they understand their asthma action plan. We all are hopeful. We can't wait till the system changes. We have to, do our workarounds that we need to do, because this is too important to wait until the FDA decides, oh yeah, I think it's a good idea. It's too important that, so yes, I'm not quite saying on the prescription what I'm actually having them do in real life.
Okay. See here. So are there equity studies on who is being prescribed SMART versus just albuterol, so we can learn more about access and how we can improve it?
I'm sure there are. I probably not able to answer that at this moment, but the current thinking is, again, this particular way of treating asthma, because it is so much more accessible across a large population, could potentially, especially if you don't need to have an inhaler every day, that you dial up when you're having symptoms for air, or even if you have mild persistent asthma and the number of puffs that you need just on a daily basis is much less than what actually is contained in the inhaler, that we probably will be able to not level, but at least decrease some healthcare disparities, at least in terms of access to quantity of medication.
Okay. I am sorry. We are at the top of the hour now. There were a lot of questions that we didn't get to, and we are sorry about that, but we're very happy for the interaction. Thank you, Dr. Hogan, so much. This has been really informative. And we have two webinars coming up in August. First, we'll welcome back Dr. David Stuckis on August 21st at 4 p.m. Eastern Standard Time. And it's going to talk about childhood asthma and how to teach children to use their inhalers properly. And then on August 27th at 12 p.m. Eastern, we're going to welcome Dr. Ann Maitland to discuss seasonal allergies and optimizing treatment for each patient. Now, you're going to receive an email from Zoom in a few days with a link to the recording and an evaluation. That's really important to give us feedback and some additional resources. So again, thank you so much from all of us here at the Allergy and Asthma Network. Join us as we work every day to breathe better together. Have a good evening, everyone, and we'll see you at the next webinar.